Okay, great. Okay, just for disclosures, I don't have any relevant financial disclosures, but I do receive some funding to study women and girls with bleeding disorders from the American Thrombosis and Hemostasis Network and the Hemostasis and Thrombosis Research Society. So objectives today are to identify causes of anemia, explain iron economy, talk about some risk factors for the development of iron deficiency, and describe some of the consequences of iron deficiency. So I spend my days thinking about blood, and it's a pretty good way to spend your days. So this is a peripheral blood smear. So looking at your blood under the microscope, the red things are red blood cells. The big white thing in the middle is the white blood cell, and then the little purple like specks across the slide are platelets. And red blood cells, which we're talking about mostly today, are biconcave discs filled with hemoglobin. And their main job is, of course, to transport oxygen and carbon dioxide. And the biconcaveness is what gives them the little kind of like mouth, or like the central part that looks pale. And that allows for easy deforming as they move through the tiny vessels inside the body. So the main protein that we're thinking about inside the red blood cell is hemoglobin. And hemoglobin is the protein that's job is to carry oxygen and carbon dioxide. And each red blood cell is contained, which I always think these numbers are crazy, 300 million hemoglobin molecules. 300 million in like one cell. And then each hemoglobin contains 4 subunits, which we call globins, and then 4 heme groups. And the heme groups are the things that contain iron, and that is what binds the oxygen. So this is just a cartoon of a hemoglobin molecule. It's made up of the 4 globin proteins, and typically adult hemoglobin, which is around even at the neonatal phase, is made up of 2 alpha chains and 2 beta chains, or 2 alpha globins and 2 beta globins. And then they each contain 1 heme group that contains iron and binds oxygen. When we look at red blood cells, we think about different types of the indices or different parts of the red blood cell. And these won't come on like a point of care hemoglobin, but they will be resulted on a complete blood count. And we look at the MCV and the MCHC, all of these other indices. And sometimes if you're not a hematologist, you're like, who cares? But these are really important when we're thinking about what can be causing somebody's anemia or low hemoglobin. And so the MCV is looking about how big are the red blood cells on average. And the MCHC is the mean corpuscular hemoglobin concentration, or what concentration of hemoglobin is inside each red cell. The MCH, I don't use that. That's just the mean corpuscular hemoglobin. It's just another way to look at the same thing, but we don't really use it. And then the red blood cell count is how many red blood cells are there? Are there a bunch of tiny red blood cells, or are there not very many and they're also tiny red blood cells? And then red cell distribution width is the population of red cells and how different it is across like size and shape. So we use these in hematology to help us think about if somebody's hemoglobin is low, what's the cause of that low hemoglobin? And I wanted to just demonstrate a little bit. This is from one of our hematology textbooks, looking at the different hematologic values across the first year of life in a healthy term infant. So this is not necessarily applicable to like a premature baby, but across the months of age, so, you know, a newborn all the way up to a 1-year-old, the hemoglobin values can change quite significantly. And so normal hemoglobin as a 2-month-old is 11.2, whereas a newborn, it might be up into the teens. And so these are just important. We always, in hematology, go back to like, what is the normal value for age, and seeing how the patient you're seeing compares. Anemia is defined as being lower than 2 standard deviations from the norm. So these are all the values of how we define anemia across the different ages in children or infants under 1 year of age. We can also look at this in this is like more information across the lifespan. And again, just seeing the variability, and not meant to look at all of these, but knowing that there could be quite a difference in hemoglobin values depending upon the age. And so maybe when you're seeing a 9-month-old, a hemoglobin of 11.5 is normal, but if they were a 14-year-old, that wouldn't be normal, or something to think about. There's this great hematologist named George Buchanan, who's in Texas, and he came up with Buchanan's Rule to tell if somebody has anemia. And this is mostly though for kids older than 1 year. And so he says if you use 11 plus their age in years times 0.1, that's the lower limit of normal. That's a little bit complicated, but sometimes you don't have your reference book right in hand. But Buchanan came up with these rules and they're pretty applicable. So when we were thinking about this as I was preparing, I know that the point of care hemoglobin is what's most commonly used for screening for anemia. And this allows for in-office immediate results. It's quote unquote just a finger poke. I always hate finger pokes, so I never am encouraged that it's just a finger poke. The disadvantages of just getting a point of care hemoglobin is that you don't get any other information about the red blood cells, but it is a good screen to get immediate information of whether this patient is anemic or not. But then it doesn't allow you necessarily to get more information to see the cause of the anemia. And then the other option is to get a venipuncture, complete blood count, and you can get all the scoop on the red blood cell, but it does require a venous puncture and it's not immediate. I wanted to think about that not all anemia is iron deficiency. And so I think I just wanted to go through this before I dive into iron deficiency anemia. So we always start with, is the hemoglobin normal for age? Lots of times when we get complete blood counts that are done at various labs, sometimes the lab doesn't have the reference ranges for age. And so it's important to just make sure, is this normal for age? So if it is, good job, you cured them. This one's so sorry, I erased the no here. So is it not? And then what we do is look at the size of the red blood cell. Is it smaller than normal, microcytic? Is it normal, normocytic, or is it bigger than normal? And then that can make us, think about different causes of microcytic, normocytic, or macrocytic anemia. And you'll see here that iron deficiency falls under microcytic anemia, as well as a few other things like hemoglobinopathy. So that'd be like thalassemia. But then we can also see lots of different causes of other types of anemia that are important to consider. So like in a new baby, like hypothyroidism might be a big deal, or we might see renal disease causing a normocytic anemia. So it's important to consider that it's not just iron deficiency. The other way we can think about anemia is thinking about it through a lens of, is the body destroying red blood cells? Is it not producing red blood cells, or is it losing red blood cells? Are you bleeding? So, and there's different things we think about for these. For destruction, it might be they have some problem with their own red cell that increases its risk for destruction. We might again see iron deficiency anemia causing production problems, or with losses, it might be a GI loss, menstrual losses, things like that. So just to think about the different types of anemia that might develop. So there are many causes of anemia in children. The most common, though, remains iron deficiency. And I think it's important, though, even though we think a lot about iron deficiency causing anemia, that we can definitely see iron deficiency precede anemia, and that you can have iron deficiency without anemia that's important to manage and treat before it develops into iron deficiency. I love this quote from Nancy Andrews and Kristina Ulrich and Mark Fleming, who are all pediatric hematologists, or were. And they note that iron lacks the glitter of gold and the sparkle of silver, but outshines both in biologic importance. So a little shout out to iron. We often think about iron being predominantly in hemoglobin, which it is, but it's also in a bunch of other proteins and enzymes in the body, and just a few of them are listed here. Just highlighting the importance of iron throughout the body and not just in hemoglobin. Another great quote from those hematologists, that human existence is inextricably linked to iron, and disturbances in its metabolism may have dire consequences. Iron is able to donate and accept an electron, which allows it to be really facile and well utilized in different chemical reactions in the body. So it can either exist in its two oxidation states, either in 2+ or ferrous, or in 3+ ferric iron. And so this allows it to act as a redox catalyst and is really important for different reactions throughout the body. But because of that, iron's super reactive, and like if it was just out there free in your body, it would cause all sorts of problems just donating and accepting electrons. So it has to be bound to some sort of chelator or a chaperone as it moves around your body. So transferrin is the protein that carries iron through the circulation. It can bind 2 iron atoms at a time, and it delivers iron to cells and allows them to take up the iron. And then, ferritin is the storage form of iron, and it can hold up to 4,500 iron atoms. I think that's amazing. And then you can mobilize your iron from your ferritin stores when you need them. So let's say you were in like a car accident and you had bleeding, then you would mobilize your iron from your ferritin to make new red blood cells to make up the fact that you just had all this bleeding occur. This is a little look at iron economy. So when you think about like what goes in and what goes out, and really looking mostly at how iron is utilized to make red blood cells, but also looking a little bit more at other parts of the body as well. So as you get iron in through your diet, you take about 1 or 2 milligrams of iron in, and it gets absorbed into your blood through the sorry, I'm just getting paged. Sorry, you guys. Hold on 1 second. I'm sorry. I'm the worst at speaking. Hold on. Oh, they hung up. Okay, never mind. Okay, sorry. It's been a weird day. There's a couple people out with COVID, and so we're all covering a little bit differently than what we should. Anyway, so you take iron in through your diet. It's absorbed mostly through your small intestine and the duodenum. It then gets used in your bone marrow to make red blood cells. It goes into your liver for storage. It goes into other tissues. If you're pregnant, it really, like, the fetus takes all of the iron from the mom. So the average adult has 4 to 5 grams of body iron, and only 1 or 2 milligrams of iron enters and leaves the body in a day on average. And then about 0.5 to 1 milligram of iron is lost each day through sloughing of skin cells, mucosal surfaces, things like that. And we kind of keep this economy like pretty tight. And then for people who are having periods, they lose another 1 milligram of iron about a day during their period. So this is like all like kind of kept in tight control, and there's not a lot of room for excessive losses. Our red cells are the ones that carry the most hemoglobin, iron, and they have a ton of iron in the hemoglobin. And then our tissues have a little bit more, and then we store a bunch in our liver, and then a bunch gets recycled as well. So in general, our iron balance is maintained by regulation of absorption. And we absorb this through, like I said, intestinal uptake, and uptake can increase up to 10 times normal in the anemic state. It's really responsive to iron status, your erythropoietic demand. So if you needed to really increase your red cell volume and you had a secretion of erythropoietin, then it would make more iron absorption occur. And then it's responsive to hypoxia and inflammation. However, loss, of course, is unregulated. Like, you can't just like turn on iron loss. And you can get, I always think about this when you're have too much iron. You can't just be like, oh, I'm going to get rid of this by like turning on a faucet of iron. But this can occur through sloughing of cells like skin and mucosa, as well as through bleeding and pregnancy. This is a look at a terrible cartoon, but I can't find a better one. And this came from a review course that I was on. And so I just took a picture of this for my notes. So this is supposed to be an enterocyte inside the duodenal villi, and it gets absorbed iron gets absorbed into these cells, then must be reduced into its ferrous iron form in order to be absorbed. And then it gets transported across the kind of like top lumen facing cells, and then transported into the cells, and then exported on the opposite side into the blood. And then your serum iron gets stored in ferritin. So intestinal iron, we think about this in 2 groups. the either heme iron or non-heme iron. So heme iron is the iron found in meat, poultry, and fish, like blood and muscle. I always like think about it and then I get kind of grossed out. And then I think about becoming a vegetarian and then I just still eat meat. And then non-heme iron, like plant foods, like vegetables, legumes, and nuts. And heme iron is much better at being absorbed. 30 to 70% of what you get from heme iron is absorbed, than non-heme iron, which is less than 5%. I think it's fascinating that we don't know how heme iron absorption occurs. And like, I love when we don't know how the body works, because I think it's just like leaves more mystery, but we don't know how heme iron is absorbed. Okay, there's some iron trafficking that also occurs within the cells. So transferrin receptor and then another receptor transport iron around. And then there's also a zinc transporter that takes up iron in iron overload states. And once the iron gets on the inside, it joins the labile iron pool, and it's then either utilized in mitochondria for protein production, stored in ferritin, or exported through ferroportin. Oops, sorry, I forgot those arrows. There you go. There's this great hormone that was discovered not that long ago called hepcidin that we didn't know about for a long time, but it's a negative regulator of iron export. Hepcidin inhibits intestinal absorption when your iron levels are high, and it inhibits macrophage iron release. So if your iron body needs more iron, your hepcidin levels go lower so that you can absorb more iron. And if your body needs less iron, your hepcidin levels increase, and then you decrease your iron absorption. So how do you become iron deficient? You either have not enough coming in, you have too much going out, you're not absorbing it well, or for some reason you have dysfunctional iron metabolism. As you guys probably are well aware, iron deficiency is really common, and this is mostly looking across different ages. This is from Nonheme's data from the early 90s, so a while ago, but it all pretty much holds true. So in the little kids, we can see that iron deficiency anemia affects 3% of those group, and 9% have iron deficiency without anemia. The other population that I pay attention to are the adolescent females, where iron deficiency is also really common, much less common in the males. So again, this is about 25,000 people aged 1 year and older, and the prevalence corresponds to 700,000 toddlers with iron deficiency, with 240,000 of them being anemic, and 7.8 million women with iron deficiency, with 3.3 million being anemic. This is updated Nonheme's data from 2007 to 2010. And so from this data, we can extrapolate that 1.5 million children ages 1 to 5 years are at risk for iron deficiency, which, as I'll get to in a little bit, we think about the effect on their development and how important screening for iron deficiency is. So what happens when you're iron deficient? What kind of signs or symptoms do you experience? Most commonly, and oops, sorry, having a hard time with my arrows, you guys. I'm sorry about that. Most often in kids, especially, iron deficiency anemia is asymptomatic, and you don't know until you get the lab, which is always challenging. But often kids might be pale. Sometimes they might complain of fatigue, but the littler they are, I feel like the less symptoms they have. We can also see pica develop, and this is just a different group of forms of pica, and you can see all sorts of things here. We just saw a little kid in clinic who was eating would only eat raw noodles, and nobody really understands why pica occurs. I've had, I always tell the story of that I was seeing a young woman in clinic, and her mom brought her younger child with them, who was, I don't remember, toddler aged, and I was talking to the young woman, and her little brother walked over to the exam table and started peeling off paper from the exam table and just eating it. And it was like he'd take off a strip of exam paper and put it in his mouth. And I was like, hey, have you ever been screened for iron deficiency? They're like, oh yeah, he is, and he's supposed to be on iron. So it, these kind of funny things that happen. I also had a kid who was iron deficient, and we came into clinic to see us, and we got labs, and we were talking to them, and we were examining them, and the kid opened their mouth to show us their tongue, and it was covered in stickers. And her mom was like, yeah, she just puts stickers in her mouth all the time. And so lots of interesting pica stories out there. But again, iron deficiency can be quite severe and still be asymptomatic in pediatric patients. So what's the etiology? So not enough in can be insufficient intake to meet physiologic needs, especially those who are rapidly growing, like the pediatric patients. Cow's milk has minimal iron in it, and it's not very bioavailable. Milk, of course, fills you up, and it may or may not cause GI bleeding. So we often see little kids who are like milkaholics, and they're drinking 30 ounces of milk a day, and they're very prone to get iron deficient. And I think a lot about, and this is the case that we saw in clinic today, of infants whose parent or whose mom was iron deficient during pregnancy and breastfeeding. The baby or the fetus is going to get most of its iron from the mom during the last trimester of the pregnancy. So preterm babies are especially at risk for iron deficiency because they didn't get their iron load at the end of their gestation. And then if their mom was anemic the whole pregnancy, like there's just not enough iron to get. And so I think aggressively treating a pregnant mom for iron deficiency is important for the mom as well as the baby. And then breast milk has not a ton of iron in it, but it's really bioavailable. But I also think if like the mom is iron deficient, she'll have even like less iron to get into her breast milk. So puts these kids at high risk. You can also have too much out. So there could be GI blood loss, like with gastritis or ulcers or parasites, and varices, inflammatory bowel disease, things like that. And then recurrent prolonged nosebleeds can cause iron deficiency. Heavy menstrual bleeding is like the most common thing I see in my spot spots and clots clinic. And then hematuria, or blood in the urine due to like chronic infections or things. And then rarely we can see problems with inadequate absorption. So celiac disease, it's really common to see iron deficiency. Somebody's had a prior bowel resection or have inflammatory bowel disease, they can all result in inadequate absorption. And there's a really rare disorder called iron refractory iron deficiency anemia that's due to a specific mutation in the transport protein. And this is a really rare cause and something we don't usually like consider until we've exhausted all other causes of iron deficiency. So when we think about what our labs look like in iron deficiency, I like this image a lot because I think it kind of looks at the different stages. So up here, this is looking at in this like diagram, your iron stores and then your circulating iron. And when everything's good, you have lots of iron in your bone marrow, your ferritin is good, your hemoglobin's fine, your red cells look nice and healthy and normal. And then all the way to iron deficiency anemia, where you don't have iron stores, you don't have very much circulating iron, your red cells are tiny, they're pale, you're definitely anemic. And then in between there, though, your red cells can stay normal for quite a while before we start to see a change due to iron deficiency. So that's why I always struggle with screening for iron deficiency with a point of care hemoglobin. We're potentially missing the kids who are iron deficient but not anemic. But ferritins require a venipuncture, which is not always feasible. All right, so let's talk about some of the non-heme effects of iron deficiency. These are some older studies, but I think they're really important. So this was a study that looked at cognitive status in patients who had been iron deficient as infants. And so they did some testing about like how they were thinking and processing, and it required moving things. And so that's what the x-axis is, the minimum number of moves to accomplish a goal, and the y-axis is thinking time. And what they found was that adolescents who had been iron deficient as infants had difficulty forming and executing actions, and they spent less time planning their response to the most challenging problems, which is concerning for executive function and processing skills. And so from this study and some other studies, we know that infants with iron deficiency anemia exhibit later poor functioning in cognitive, affective, and motor domains. and lack of sufficient iron early in life negatively impacts myelination, dendritogenesis, synaptogenesis, neurotransmission, and neurometabolism. And these effects may be long-lasting even despite treatment. So I always think about these kids that we're seeing that have been iron deficient for a really long time, and I'm like, oh, we got to get you your iron up so that we can at least mitigate some of these effects. This was looking at patients with iron deficiency and cognitive stores and comparing patients with good iron status, and then also looking at socioeconomic status, comparing low and middle socioeconomic status. And what they found through these studies is that food supplementation eliminated the decline in test scores that were associated with lower socioeconomic status, and that these studies provided support for long-term cognitive benefits of improved nutrition in infancy, and prevention of chronic iron deficiency in infancy may have significant long-term socioeconomic status. So really important to like catch the iron deficiency and food insecurity early on so that we can hopefully help decrease the effect going forward. And then this was another study looking at the Nonheme data of about 5,400 children ages 6 to 16 years who had done blood work and 2 standardized tests of cognitive function. And they defined iron deficiency as ferritin less than 12, and then if they were anemic if their hemoglobin was less than 5% for age. And for in this study, children with iron deficiency were more than twice as likely to score below average on math tests, and the difference in math scores was most striking in adolescent females. And this is here, so across the top here, we have normal iron status, iron deficiency without anemia, and iron deficiency with anemia. And this is percentage of children scoring below average by iron status. And so we can see that there was more patients scoring lower with iron deficiency, anemia, and math. And then here's that difference between, it was more striking in girls. So I always think about this and how there's this like fall off of girls in STEM right at their teenage years. And is this related to us under treating iron deficiency in this population? And then I think about this is the time when you start having your period. And so then that makes you more at risk for iron deficiency. So this is why I'm always pushing for our teenage girls to get their periods taken care of and their iron deficiency addressed so that they can be better at math and science and like take over the world. So again, some non-heme effects. We know that in older patients and women with heavy menstrual bleeding, iron deficiency is associated with lower health-related quality of life scores. And fatigue is associated with lower ferritin levels. In children with iron deficiency anemia, there's a higher risk of depression, bipolar disorder, anxiety, autism, developmental delay, and attention deficit hyperactivity disorder. So iron deficiency doesn't necessarily cause these things, but when you already have these, you have especially an increased number of symptoms. So now let's talk about treatment, because if we find it, we should probably treat it. So we know that diet alone is usually not enough once you've identified iron deficiency. But an iron-rich diet will help prevent iron deficiency in the future. So if you find iron deficiency, we need to supplement, but it's good to create new habits to help prevent recurrent iron deficiency. When I think about this, I think we got to correct the cause, stop the bleeding, stop the milk intoxication, whatever it might be, put them on either oral or IV iron supplementation. We used to recommend a ton of iron and in divided doses. And this wasn't quite right, and I'll show you a little bit more about that. But I will say there's tons of different iron preparations, and most of them are over the counter, but have varying amounts of iron in them, and so you have to see what they have. There was this study that looked at how much iron should we be giving little kids, mostly because they were trying to compare these 2 different iron preparations, one iron polysaccharide and one ferrous sulfate. And iron polysaccharide tastes much better than ferrous sulfate. And they looked at the difference between iron correction and this better tasting iron than this bad tasting iron. And they basically found that the bad tasting iron did better than the good tasting iron, but there was poor compliance with the bad tasting iron. So it's really like whatever iron you can get in is better than no iron. But through this study, what they found is actually lower iron is maybe better than higher iron, and that we should really do like 3 milligrams per kilogram per day, and it should be given as a single dose and not divided. And what this led to, or this connected with some other studies were done, and this is like a complicated study that somebody did comparing different doses of iron and giving them once a day or twice a day. And they ended up finding that when you give iron twice a day, you get increases of that hormone hepcidin. And what we know is that hepcidin inhibits your iron absorption. So they're finding that you would take your iron in the morning, your hepcidin levels go up, and it blocks the absorption of the evening dose of iron. So this actually changed recommendations to say we should be dosing daily or every other day. This was a study that was done in adults, and it was done in patients that were iron deficient but not anemic. So we haven't reproduced these in children, but it has made us all think about that maybe more iron isn't better, especially because nobody ever takes their iron. And so if you could like negotiate to take every other day, that might actually be just as effective. So if somebody's iron deficient, we usually just do the single dose of iron. And in adolescents and young adults, we can use just the pill that is common of 65 milligrams. But in iron deficiency anemia, we know like when your hemoglobin is low, that the iron absorption is increased because the body's responding to that demand for erythropoiesis. So your body will increase your iron absorption. So you can kind of take advantage of that physiologic effect. It's not as good when your iron is low, but your anemia is normal or your hemoglobin is normal. So I will sometimes do a higher dose initially and then back down. So to get it to absorb better, sometimes taking it with some food that contains heme iron can help you absorb it. And then vitamin C can help you absorb iron as well. But calcium in tea and coffee inhibit iron absorption. I'm always like shocked by these numbers of how much tea and coffee can decrease iron absorption. So actually like as a tea drinker, I'm always like, I don't think I ever absorb iron. But I generally will say use whatever iron will make the patient take their iron, because the only way to like, get iron corrected is to actually take the medicine. There are some good studies looking at the effect of iron deficiency beyond the correction of the hemoglobin and ferritin. And in this study, which I won't go all the way through, but they did a bunch of different learning and like attention scores, and they found that iron supplementation in non-anemic adolescents improved verbal learning scores over time, but didn't affect their attention scores. And this was like a very big meta-analysis, and they found that iron supplementation in children improved global cognitive scores, IQ, and measures of attention. And iron also improved the height in iron deficient children and weight in anemic children, and iron supplementation reduced anemia risk by 50%. So it's a good argument to do some iron supplementation. And then in this meta-analysis, they found that iron supplementation improved fatigue scores, and this was in adult women, and they found this was most likely for people who had presented with a ferritin of less than 50. However, most people don't take their oral iron. I always am like, when I talk to my patients, I'm like, do you take your iron 2 days a week, 3 days a week? And I get pretty happy when it's at least 3 days a week. So I give a lot of IV iron as a result of that, because it's faster and they don't have to take their medication. But original iron preparations that were IV resulted in a release of free iron, which resulted in a lot of toxicity. And so then eventually they added a sugar to the IV preparation as chaperones, but there was still some toxicity like anaphylaxis. And so then some newer formulations were made, and they're much better tolerated and have a really low rate of allergic reaction. However, there's still a small risk of anaphylaxis while getting IV iron. These are the main IV irons that we use: Venofer, Injectafer, Infed, and Ferraheme. And a lot of them we can give one dose and correct the iron deficiency completely. So it's a quick way to get your iron corrected. However, sometimes insurance doesn't cover these, and so we have to do a lot of arguing with insurance companies to get the IV iron into the patient. In this study, they looked at IV iron in adolescent women, and they found that fatigue scores improved over time. And this was like a baseline patients that had lots of symptoms of iron deficiency. And so they found that over time, the patients had improvement of their ferritin, but also their quality of life scores improved significantly. And there were no adverse events in this population. So my approach to IV iron is that if somebody's like, I can't take my oral iron, I'm like, great, sign you up. If they said they aren't going to take it, they can't tolerate, either way. If they've been on oral iron for a long time and their iron parameters haven't changed, I give them IV iron. If they still have severe anemia, they still have significant blood losses, they understand the risk of their adverse events, mostly I give a lot of IV iron. And I think sometimes I think about those graphs that show that the effects of iron deficiency in infancy can persist into adolescence with regard to cognitive scores. And I think most of the time it takes 3 to 6 months of consistent oral iron to correct your iron deficiency. And so during that whole time, we're like seeing the effects of iron deficiency when I could just give them 1 dose of iron IV and correct it all. And could that have a better effect long term? I don't know, but it's hard. Like I always feel like I can give them iron, so why shouldn't I? So just in summary, iron deficiency is really common, especially in young children and adolescent women. Iron deficiency can result in a variety of symptoms or none at all. That's why we have our screening programs. Screening in high-risk populations, regardless of symptoms, is important. Iron deficiency can have long-lasting adverse effects on cognition, and treatment of iron deficiency can be difficult, mostly because it's disgusting, and IV iron is always an option. So this is my like stuffed blood cells. These are supposed to be platelets and white blood cells and plasma. This is anemia. So I'll stop there, and I'm happy to take questions. I'm going to stop sharing my screen so I can see your names, if not your faces. I'm going to read the comments here. So ferritin is the best measure of iron deficiency and adequacy. Yes, that's true. Some things can cause a falsely elevated ferritin, like chronic inflammation. And in that case, sometimes it can be helpful to get some of the other iron labs, like a total iron binding capacity, but ferritin is your best way to look at iron deficiency in general. How common is hereditary iron deficiency? So a lot of people claim that they have a hereditary iron deficiency. I get this a lot too. So I think that it's not common. So there's lots of hereditary anemias like thalassemia or hemolytic anemia, things like that. But hereditary iron deficiency is really uncommon. But iron deficiency is really common. So I think that it's more that iron deficiency is common rather than it's like being inherited. Black tea for the anemic toddlers. That seems not good. Okay, do you think multivitamin iron with iron drops should be recommended to all mostly or fully breastfed premature gestation infants? This seems to be consensus. I haven't looked. So my like challenge is that I don't have. Yes, I think so, but I don't usually get involved in those in like that part of their premature management, but it seems reasonable that somebody who's getting breastfed and who was premature would be at high risk, and then multivitamin with iron is a low risk intervention. Any recent studies that associate the mom's low iron status with low iron in breast milk? I haven't seen one recently. I was looking before we started because I was thinking about this case that we saw in clinic. There was one. I'll try to pull it up here and put it in the chat. But it was looking at iron in breast milk and just talking about how there's not very much of it, but that we don't totally understand the absorption of iron in breast milk. And I would love, so the OBGYN group here at OHSU is being like more and more aggressive about treating iron deficiency in pregnant people. And I've been like trying to get them to study the infants of those people that they're more aggressively managing iron deficiency, because I think they're probably preventing iron deficiency in the babies, but we haven't figured out how to like coordinate on studying that. But I'll let you know if I find anything more about mom's breast milk. Gummy vitamins and iron. Well, I think that most gummy vitamins probably don't have a ton of iron in them. And so there's like one brand that I've seen that has like, it's an iron supplement that's gummy. But most like of the multivitamins with iron don't have a ton of iron in them. I think the challenge, like when I like think about like what the dentist would say, I think they'd be anti-gummy vitamins. And so I think that's where like, I don't know that it matters for the iron part of it, but for their teeth, I always feel like gummies are probably less than ideal. Yeah, for the anemic kiddos, tearful, easily aggravated, and non-compliant, they'd be really zoned out, not very responsive, more severe anemia. I think that there's certainly, like, I feel like kids who are really anemic, like they don't feel very well. Like maybe they don't have a ton of, they're not tachycardic maybe, or they're not like passing out or anything like maybe what we would do, but I think they don't feel well. And sometimes I think this is super anecdotal, but my experience is that when they're really anemic, that they don't eat as well. And so then they like get more iron deficient, and it's like this like continuing like path. So I agree. I feel like you can see and you're like, oh yeah, your hemoglobin's going to be low. And then with regard to referral, I really think that most of these kids can very much start with their pediatrician. And that is like the best, like the good place to start. One, because they can get a full CBC and look to make sure, does this make sense that they're iron deficient, or does it, is there anything else going on? And that most of the pediatricians like should be able to start iron supplements and get them going, and then should refer to us if there's challenges with taking the iron. And I realize that like, I wish we had the capacity and the space to be able to just like, you're iron deficient, like you get IV iron, you get IV iron, you get IV iron. And like, we just like had like a little IV iron, like food truck. We could get everybody IV iron everywhere, but we just don't have that capacity. And so we have to kind of do some triaging to see who can come in. And so I think starting with their pediatrician is a really good place to start. And then if needed, we can see them. But we just like don't have like the physical capacity to see every kid with iron deficiency because there's so many of them. And I think it's reasonable to get them seen by their pediatrician. How long does an IV iron treatment take? The infusion itself is about an hour, but it usually takes like an hour to like get the IV in and get the medication from clinic. So I always tell people it's like a 2 to 3 hour clinic visit. And most of the time, these are fully covered by insurance after we do a little little appealing and fighting with the insurance company. The cost might be the copay of the clinic visit, but usually shouldn't be more than that. I think I answered all the questions.
Dr.
Are there other ones?
Yeah, this is Cheryl.
Yeah.
As I mentioned, during this time, WIC services have been provided for the most part remotely. And I think a lot of us are just really concerned that we haven't been able to check iron status and just the flood that might be coming in. What have you noticed to be true during COVID? Have you seen a decrease in the number of referrals and
Yeah. You know, at the beginning, like at the very beginning of the pandemic, we definitely had decreased referrals. And then I would say recently they have ramped right back up. So we're seeing lots of kids. I think lots of iron. Like I feel like I've written for IV iron, like I don't know, I was just thinking about it yesterday. Like I wrote, I don't know how many doses of IV iron this week. So I feel like there's tons of iron deficiency out there. I think what's hard is that, especially in the older kids and maybe in the younger kids too, but I feel like especially in the older kids, like people just don't feel good right now, right? Like there's lots of anxiety and depression and overwhelmedness, and people are just like, things are hard. And so then they are presenting, you know, complaining or feeling like not complaining, but like complaining as in their chief complaint that they don't feel well or they're feeling fatigued. And then somebody gets ferritin and it's low. And so then we're treating the iron deficiency. And I think that it helps them feel a little bit better, but it's probably not the end all be all for everybody's symptoms. But, you know, like I think people just don't feel good right now. And so then we're seeing more iron deficiency because people are doing like more labs to be like, why don't you feel good? It might be partly that they're low on iron, but I think it's also partly that like the world is real challenging right now. And so then I always, you know, when I see those patients, I say, well, let's correct your iron deficiency so we can eliminate that as a contributor to how you're feeling. But we also, you know, you need to address all these other things that are going on in the world. I think from the littler kids, you know, I haven't seen, it's more the adolescents that I've seen an uptick. I haven't seen it quite as much in the little kids, but I think about the kids who, who are now, I think I was just thinking about my sister's a kindergarten teacher. And this year she said, you know, all these kids that I'm seeing in kindergarten have never been to school before or never really been in daycare. And so this is like the first time I'm like, they're kind of being seen in their interactions with other kids. And so I think then sometimes that can like pull out like, oh, their behavior is different or something's not going on, you know, something's different. And then that can result in then lab draws and then that finds their iron deficiency. But I do think, I'm guessing that we'll see like an uptick when we do more screening as kids get back into the different places. There was a question about increased risk of iron deficiency in babies under 1. They're given milk instead of breast milk or formulas because milk is so low in iron or because it's causing GI bleed or combo or both. I don't think so. Like, I think that the littler babies are at risk for iron deficiency, probably related a lot to the mom's risk of iron deficiency. And cow's milk, you know, usually there's good iron in formula, but once they're older and they start getting cow's milk, if they get exposed, if they like become, like I always say, like milkaholics and get tons of cow's milk as they get older, then that's when we start to see more iron deficiency. And it's, I think, a combination of cow's milk has not very bioavailable iron. It fills them up and they won't eat anything else. And then there's some data that maybe it causes some GI irritation and then bleeding. And then absolutely food insecurity can play a role. And I think, certainly plays a role. And then does IV treatment have to be done at a specialty clinic? It's really more about it. So it can be done at an infusion center. And it depends on if the infusion center is comfortable with children. So like our infusion is a pediatric infusion center. And so we'll see any aged kid. But there's not a lot of pediatric infusion centers across the state. So I can often get like a teenager into an infusion center and like, I just had somebody go to someplace like they can, like Riverbend will do it, or in Eugene. I just had somebody go to one of the Warm Springs infusion centers, and that worked out great. There's one in Hermiston that will do younger kids, but it really depends on the infusion center's comfort with the age of the child, and they usually will only see people who are like adult size, unfortunately. So if there's a little kid that needs IV iron, then they end up needing to come here, or they could go to Randall, the other children's hospital.
Any other questions for Dr. Haley? I was curious about the patient that you said you saw today.
Yeah. He's like really struggling with, like, they cannot get him to take his oral iron, and he was very, very anemic. And so we're going to bring him in and give him some IV iron, and then hopefully that'll make him feel better, and then he can start eating more things. But he like refuses to eat any food. So I always think there's like some amount of stubbornness, because like these are mostly toddlers, and so you get like stubborn toddlers who then don't feel well because their hemoglobin is low, and then you're like in a battle of like just trying to get them to eat. So we'll bring them back for some IV iron and hopefully get them better.
I think what really struck me, Dr. Haley, is when you said that 3 to 6 months of oral iron is needed to correct iron deficiency versus 1 dose of IV iron.
Yeah.
And I'm kind of thinking like in the WIC clinics, you'll just hear this ongoing issue of like, yeah, we've been dealing with it. Yeah, he's on oral. It's like, at what point do you suggest, well, maybe we need to think about another plan of treatment?
Yeah. And I think, like, sometimes I feel like pediatricians like send the patients to us to to kind of like scare them into like taking their oral iron. It's like, oh, you have to go to the scary pediatric hematology clinic, and like, because I think there's like, until you've like tasted oral iron, I feel like you're like, why don't you just get your kid to take this? And then you're like, oh, this is really disgusting. Of course they don't take this. But there are some better tasting oral iron supplements out there, but you just, like I said, have to be really careful, because some of them are like better tasting, but they contain so little iron. And so, you can try a different formulation. I think if they're like consistently taking it and they're still not making any improvement, then I think it's a good idea to try something different. Like I said, I wish we could just see everybody and give everybody IV iron. I think like the more, sometimes I get on this, like, I don't know, I get a little like despondent about the fact that we can't just give everybody IV iron and just make it easier. Because I think it's like, I feel like we've always just been like, oh, it's just iron deficiency, no big deal. And I just don't think that's the right approach. And so I think you're right. Like after like 3 or 6 months of taking oral iron, either you need to try a different formulation, or talk to their pediatrician about that. Like, would it make sense to do a referral to one of us so that we can get them some IV iron? There's, a bunch of different iron formulations, but even I was just talking to this patient about so Novaferrum tastes pretty good. But it's like $26 on Amazon. And that's probably just going to be like a month's supply. And so like, that's not cheap. And so, yeah, there's lots of problems here to address. And then I think about, okay, like how do we then prevent the iron deficiency? And that's addressing the mom's iron deficiency during pregnancy, getting access to good nutrition early on. And those are all really hard too. So I'm sorry, I don't have I feel like very ending on a sad note, but I think it's just, I am grateful for all of you doing the work that you're doing. I do have a list of better tasting supplements. I can share it with you, Cheryl, and then you can give out, and then it has some different options. The other thing, like the other day I was talking to a young woman and she's like, oh, I've been taking my iron, and we were like talking about, do you take it with food? And she doesn't, which is fine. And then I said something, I can't remember. And she said, oh, well, I do take it with my calcium supplements. And I was like, oh, okay, you got to stop doing that. And so then sometimes like doing a little bit more digging about when they're taking it. Oh yeah, the flavored ones are better. And then sometimes, so OHP, I don't know about the moms and how, if it's hard to get OHP to approve it. Sorry, I don't take care of them, so I don't know. It can be, I just had somebody where I was trying to get IV iron approved, and they were going through a few hoops to get it approved. And sometimes I feel like it goes so easy, and sometimes I feel like they make you like do like, I don't know, all sorts of tricks to try to get it approved. And I haven't figured out like when that happens and when it doesn't. But I just have like a standard appeal letter that I send when they decline it, because it happens so often. I just like send it the same letter.
And Christine, yes, I would agree that it would be wonderful if all pregnant moms got prenatal vitamins free of charge.
Yeah, why isn't that a thing?
Yeah, why isn't that thing? Yeah. Yeah, I do think that there is an opportunity that if, you know, I think Julie Reeder's on the call, our research analyst, and just being able to make some recommendations for OHP and try to decrease some of these barriers for coverage. It shouldn't be this hard to navigate Medicaid and OHP. So
yeah, I'm listening, Cheryl.
No.
yes, thanks, Julie. Yes. We are approaching about 2 minutes to 5. If we have one more question for Dr. Haley. Excellent presentation, and this is a really important, critical cross-section of the population that we share between WIC and the services that you provide in your specialty clinic. So I think as we start to open up for in-person services, there may be a lot of screening being done and possible referrals happening. So thank you so much for being available for this presentation and for your knowledge and expertise. It's really wonderful.
Absolutely, my pleasure. And I think, you know, like I always think like the more patients that we end up needing to get figured out to get them like IV iron, the bigger push it makes for the hospital to expand access. And so, you know, if I get to be able to go to our department chair and say, hey, I have, you know, 100 more kids and I have space for it to do this. And this is important for development and growth and all these other things. And, you know, I think it's an important thing to advocate for.
Yes.
Happy to keep going.
That's excellent. And it sounds like you are advocating when you've got more, I think I heard that there was more screening being done of pregnant women. So that's excellent news all the way around. Yes. Yeah. Well, thank you so much. And we will remain in touch. Your slides will be shared out or have been shared out, and your presentation will be posted. So thank you so much for making that available for WIC dietitians who weren't able to attend today.
You're welcome. Thank you for having me.
Thank you. Have a wonderful afternoon.